very much for the Harvard Global Orthopedics Collaborative for having me today on talking about complex cases of humeral shaft non-unions. So my name is Pierre-Marie Woolley. I'm an orthopedic trauma surgeon. I'm based in Port-au-Prince, Haiti. I'm currently the co-chair of the department and an associate professor at Lapa University Hospital, which is the residency program and down in Port-au-Prince. So it's really great to be with you all, and we'll talk about some of the key points to know about humeral shaft non-union treatment, especially in low-income settings or low and middle income countries. So I have no disclosures. To start talking about non-unions, one of the main things that I personally do is basically kind of define what is a non-union. And it's really talking about the healing process of whether the bone is going to heal or not after a fracture and what mechanism will prevent it from healing. And everybody, every book, every textbook, and every text that you will read will give you a different definition of what is a non-union. Talking from mechanical standpoints or from biological standpoints, and most definitions are really subjective, with the criteria's result in high inter-observability. So depending on who or what surgeon is treating these cases, their definition of a non-union will change. The best one to date, I think most trauma surgeon approve, is the one from Dr. Wiss that was published in JOS in '96. Well, he basically said that the designation of a delayed union or a non-union currently made when the surgeon believes that the fracture has little or no potential to heal. So it's not really a question of timing or the 6 to 9 months that was initially advocated for many years. It's really when you're looking at serial x-rays and not being able to see that there's a progression or some sort of callus formation. And I always like to go back to the old articles because I think that's where you get the most of definitions and the most classification. So the Weber classification on non-unions, it's a 1976 paper, really kind of defined the different types of non-unions and kind of put everybody in the same spectrum of where you can actually treat them and which cases are going to be more difficult to treat. And so they define it as hypertrophic non-unions, oligotrophic non-unions, atrophic non-unions, which basically is avascular, and then the actual pseudoarthrosis when after more than 9 months to a year, there's actually a pseudo joint form at the non-union site. And those are very critical to understand up front, looking at humeral shaft non-unions, because each of them are a different animal, each of them has to be treated differently. So humeral shaft non-unions are characterized by the arrest of a fracture and the process of the healing. And usually what happens is it's either from non-operative treatment or from operative treatment. And each of them are different outcomes. So diagnostic can be made with plain x-rays. There's no need to go more than that. If you have serial x-rays and most cases you treat non-operative for the humeral shaft, then you will have a pretty good idea of if the healing process has begun or is or not. Sometimes if you have access to a CT, you can actually use it. This will kind of extend the bridging callus, see what you can actually utilize if you're going to do for preoperative planning. But most times I don't personally use it. We don't have access to it, and just plain x-rays is standard. And then the treatment is generally an open reduction with compression plating, with or without bone grafting. So we're talking about cases where you have a non-union at the humeral shaft, and you want to have maximum compression, and you don't necessarily need to go bone grafting. And we'll kind of touch base on a couple of cases to illustrate our point. So the incidence of primary non-unions depend on what initial management was done for those fractures. So it goes up to 33%, which is pretty high for non-operative management, and then it's between 5 and 10% if those cases were done were treated surgically. And people are now moving away from certain types of fracture pattern for non-op management because of the risk that is elevated, especially if you have comorbidities, which we'll see in a minute. And then where is it located? So proximal third humeral shaft fractures are felt to have the highest rate of non-unions, and this is due to the vascular anatomy of that region. But I think pretty much the most important factors that will contribute or not to a non-union are either biological or mechanical. So biological, you have metabolic diseases, osteoporosis, vitamin D deficiencies, patient-related factors. Smoking is a big factor, obesity, malnutrition, and non-compliance of the patient for the actual treatment. And then, of course, open fractures, which will probably lead to infection if the initial treatment wasn't done right. From a mechanical standpoint, unstable fracture pattern with inadequate stability will likely result in a non-union. And then you can also have shoulder and elbow stiffness, and then which will put motion directed onto the fracture site. And I think it's really critical to kind of do a triage of the patients prior to any surgery of a non-union, especially if those factors are not addressed. So even if you do a perfect surgery, if you're not addressing some of those patient factors, you might have a really bad outcome. So non-op versus operative, this is classically done. Initially, there's some data that suggests that some electrical stimulation, ultrasounds may help, but it's nothing concrete. As well as extracorporeal shock wave therapy, or just leave the coarctation splint or the Sarmiento splint for a longer period of time, which is sometimes very difficult for the patient to tolerate, especially in young active patients. And then operative treatment, you take out the hardware if there was an osteocentesis. You can either do a plate osteocentesis or double plating osteocentesis. You can do an intramedullary nail. Sometimes external fixation has its role, especially if you have an infectious stage 1 non-union, where you kind of take off the infection. Autogenous bone grafting, bone marrow aspirate. So if you have RIA or some type of implant that can give you that, autograft bone DBMs, and then you can also do platelet concentrated. So there are multiple options for kind of addressing a non-union from the humeral shaft. Some of them in combination with other treatments, but the idea is to give that patient the best chance of healing without multiple surgeries. And sadly, most of the options that I've stated are not necessarily available in low income countries, which will put the situation a little bit more difficult to treat, especially if you have an infected non-unions. And we'll see a couple cases on that. One thing that you can control, and this is probably the most important slide of this talk, is that it's what you're doing as a surgeon. If you understand the pathology, if you understand the mechanical limitations of a treated non-union, then you should really think about your osteocentesis and which implant you're going to be using and which patient you're going to be using it in. And those are all cases. Some of them are mine initially, where we failed either by putting the wrong implant or putting an implant that wasn't adequate for that fracture pattern, or just using an implant that biomechanically speaking was not the proper implant to do. So other things that you can control is really your stripping. So the more you have excessive soft tissue stripping, the less chance you have of healing that bone and you have a vascular compromise. And then, as we mentioned before, improper or unstable fixation, right? You want to have absolute stability. You want to really gap due to the distraction, and you have to have really good reduction. And then you do not want to have excessive motion. And then you can either do a direct or indirect reduction. Implant size matters. The number of screws you'll be putting proximal and distal to the fracture site matters. If you're going to be bone grafting, your indications have to be solid, and then your location of your incision. In terms of surgical approaches, my personal preference is interlateral with a brachial splitting, but I think it really depends on what prior surgery that was done, and if you have a surgery that was done initially from one incision, you can just utilize the same incision to go back there. Just be wary of the fibrosis tissues and other aspect of that. So posterior tricep splitting or posterior tricep sparing depends on where at the level that you are. All of them are good approaches, but if you're doing a primary revision, my preference is interlateral approach. You get direct access to it, and you can actually protect the radial nerve without having to dissect it. So we're gonna do a couple cases, and then this is really where we're gonna kind of see all the different elements that we've stated. So case number one, this was one of my patients. She's a 45-year-old woman. She fell from a motorcycle in the Dominican Republic, which is our neighboring country, and she was initially treated, which most cases would be, with a U-shape and a sarmental splint. And so 4 months after the injury, there was no callus. She had pain, swelling, and limited motion. She wasn't infected, but she's a really, really big smoker, like at least 2 packs a day. And so we initially talked about a delay union, but with serial x-rays, we stated that this was a non-union in progress and the union, and we wanted to do treatment for it. So the best option, then you can debate, you could nail this, you could do a plate or dual plating. In her particular case, we went into a double plating fracture construct, and we did not bone graft. So this, normally you would use a longer plate, especially if you're doing an interlateral approach. But the fact that you're doing a dual plating with at least 6 cortices proximal and distal to the fracture site in a DCP compression mode, and you're adding an extra plate for extra stability, actually gives you a really good stable construct, and that patient actually did quite well. And then this was done through a posterior approach because he wanted to actually see the radial nerve and to kind of liberate a little bit of that. And in this particular case, we used 3 5mm screws and your small frac set, and this was sufficient. A second case, a little bit more complex now. So we defined the non-union. This one was, again, a young patient, a motor vehicle accident that was treated with in a different institution with a plate that a year out from the injury, not infected. The patient did not have any risk factors, but because of the lack of stability at the fracture site, he had an hypertrophic distal third non-union of a humeral shaft with failed implants. And you can see the amount of callus that was done proximal and distal to the fracture site. So in this particular case, I think it's pretty straightforward that stability is what was missing with it. And again, you have serial possibilities. And then my preference of choice is using a long DCP plate construct, but you can see how many screws we put proximal and distal. So 8 cortices proximal, 8 cortices distal. And we did, in this particular case, took down the callus from the hypertrophic non-union and used that callus as bone graft at the fracture site, giving it the maximum of compression with a good outcome. You did not need to dual plate this one, although we could have done that. We felt that the construct was sufficient, and that patient actually ended up healing quite well. A little bit more complex is this one is an older patient, obese, smokes at least 2 packs a day, had a gunshot wound to his distal third humeral shaft, and was initially treated at an Austin institution with a first plate, and they added a second plate, a posterior plate, on top of the first one that failed. And we had, in this particular case, an infected atrophic non-union of a highly accumulated fracture. So now you're getting into more complex fracture fixation. And the first thing to do is to take as all this down and to kind of see it, where you can actually treat the infection. So we initially did antibiotic beads with external fixation, and we went into treating this definitely after 6 weeks with a different kind of construct, which is a big 4-5 recon plate with 4-5 screws instead of 3-5 screws, with maximal compression, iliac crest bone graft after taking off the beads and making sure that we had negative cultures. And so from that initial masculate type damage control, we ended up with a solid fixation and actually good results. And we also added a Juda decortication, which we'll see in at the end of this presentation, which is a very old technique, but is very useful in those kind of non-unions. And so that patient actually went into really good healing. Still a little bit of limited in motions at the elbow. And since he already had a radial nerve palsy, we went into doing a tendon transfers to kind of give him back his dorsiflexion of the wrist. But the outcome was actually pretty good. And last case is when you have a really big gap, and you this is a patient of mine, a 22-year-old with a gunshot wound. Ironically, she's actually neurological intact, with a firing radial nerve, but she had a big gap in the mid shaft of the humerus, and she was 3 years out from injury. So basically infected non-union again, with loss of pretty much 2/3 of the humerus. So we did a stage mascale a procedure just like the case before, made sure that we had a non-infected bed after putting a cement spacer on. And then we put an external fixator distractor on it, and to do bone transport as secondary procedure. So the bone transport kind of went on quite well for a couple of months. And now she's at the phase where we're going to be shortening a little bit, bone grafting with iliac crest bone graft. But you can see how much you can reconstruct even the humerus if you have that amount of soft tissue and bone defects, as long as you make sure that you don't have any infected bed. So a couple words on iliac crest bone graft. It is still widely used around the world. It is easy. It's a lateral window. Make sure you have enough bone graft. It's okay to take more than needed, as long as you have, as long as you can measure the amount of bone graft you'll need, and then you can actually do pretty good compression if you're doing a double plating with that. And to finish, the Juda decortication technique, again, going back to really old technique. The Juda actually described this in the 1970s, where he's basically taking an osteoperosseal decortication, so what they call a muscle pedicle decortication graft. And he used it for treatment of both septic and aseptic non-unions. And this technique actually was reviewed and published in Injury by 2 groups out of India. And they combined the Juda technique with compression plating, with an upper and lower extremity, and with or without bone graft, as long as you had a stable construct. Make sure you had a good vascular bed. You did not strip off the periosteal area of the humerus shaft. You would have a really good outcome. So it's the basic principle of taking so fishtail aspect of the bone, keep the bone intact to the muscles, and this will give you a really good result. So this is the papers that were published, and I really encourage all of you to read it, because it may be an old technique, but it has great merit, especially in those really complex cases. And the outcome from both from Judea initially, and the other ones, small numbers for the Indian groups. Judea actually had over 800 cases, some of them, most of them with tibia, but he had he described around 90%, 94% results healing, and the two groups actually published 100% and 90%. So that was with the tibia, but it's also applicable to any long bone. So in summary, depending on the fracture pattern, starting from the basic transverse, if you don't have good reduction, you really have to have good stability, or your risk factors or nonunion are going to augment. If you have any comorbidities, they actually play a strong role in the development of non-unions. So you need to address those issues at the same time or prior to your actual fixation. Otherwise, your risk of failure is gonna be bigger. You really need absolute stability to get treatment of those non-unions. And then removing soft tissue, you need to add a biological substitute, because if you do, then you will not have the result that you want. And then basically, there are multiple options of treating a non-union, but plate fixation with relative or absolute stability is the go-to method to do so. Thank you very much. I look forward to hearing your questions and comments about this talk, and I enjoy the Global Orthopedic Collaborative webinar on complex cases of the upper extremity. Thank you.